I guess the subject here is talking about the challenges, incentives, and impacts on healthcare innovation. Innovation is a very, very tricky subject in the sense that, yes, number of us have come up with great ideas and thoughts in the past, but how do we really implement them and make use of them and perhaps even commercialize some of these ideas? It's a very, very difficult job to do. It's not as easy as just coming up with an idea and say, hey, I've got a great thing on a piece of paper, but it works really well, but how do I really make something out of it? How do I get the community involved, the nation, the states, whatever it is your markets are? Let me give you a very short story. Going back from our Hindu mythology, the Puranas, there was a young kid, very, very poor, about 18, 19 years old. And he was living in a village and saw the most beautiful, gorgeous-looking princess ride by him on a horseback one day. And within seconds, he fell in love with her. And he goes and tells his best friend, says, listen, now I've got a major problem. I've fallen in love with this young princess, and I want to get married to her. So this guy actually was in the business of making these gliders, that can really fly. So he tells him, listen, I think you should just relax. She's a princess, and you're a nobody. You're going to get killed if you go anywhere close to the palace. He says, no, nothing doing. I really want to go there. So he says, okay, the best thing I can do for you is to make this glider. And you do whatever it is after that, and goodbye. So he agrees and gets onto this glider and lands in the palace one fine evening and meets with this young princess and says, I'm Lord Vishnu. That is, in Hindu mythology, a great, great god. So instantly she says, okay, what can I do for you? He says, I want to marry you, but you have to keep this hush hush. So she agrees, gets married to him, and every day, he comes home with this glider back and forth. And one fine day, there is a little bit of a commotion, and the king hears about this and summons the daughter and says, what's going on? So he says, well, I just didn't tell you this, but I just got married to the great Lord Vishnu. So the king is very, very happy about this and says, okay, can I meet with this gentleman? So rightly so, she introduces him. And lo and behold, what has happened here in the kingdom is that the neighboring kingdom is about to attack this king. And so he says, I'm very relaxed. He calls his general and says, General, we can really put Vishnu to lead the army. So, in one blow, he's going to wipe off the enemy. So this guy is summoned and says, listen, this is what's going on. And so he tells the general, why don't you get all the elephants and the horses and everything? He says, we hardly have anything here. Maybe a couple of elephants, a few horses, that's about it. So he goes back to his friend and he says, I'm in trouble. They want me to really lead the army to this war against the neighboring kingdom. So his friend said, I told you so. That's the end and goodbye. I cannot really help you anymore. So he goes back and he says, okay, this is my end. Rides that elephant, the lone elephant, and whatever the number of soldiers he has got following him, he starts to ride. So at this point, the real Vishnu is woken up by his assistants and says, listen, there is a guy down there who's pretending to be you. And in case, he's very much going to lose this war. And if he loses, everybody's going to think that you're no good. So you better do something about this guy. So the real Lord Vishnu comes down and, cut long story short, helps this kid and wins the war, and all of a sudden, he's a great hero. So I'm going to come back to this story in a little while as to why I'm narrating this story, because this has been of great help to me in all my businesses, whenever I've innovated or otherwise. Because whenever you innovate and you don't really have a Vishnu, you're in very big trouble. Like Anne here is our Vishnu at Ivy. Okay, and anything we have to do, we just have to make one phone call and we get things done, right? So we need to really have that very much of a person in any aspect when we come up with an innovative idea, and more often than not, we fail to really enlist that person in our business, and all of a sudden we wonder what's going on. Why is my idea not selling? Why is my innovation not really progressing? Because we don't really have a Vishnu to back you up. So when I was in 2008, came up with this news item, a young kid at Tampa General Hospital was a cancer patient. And the parents wanted to send the images and CT scans and reports and stuff like that to Memorial Sloan Kettering for a second opinion. They put the entire package in a FedEx envelope and sent it across. And by the time the oncologist at Sloan got it, the kid passed away, and I guess what I read was the fact that the oncologist said, I wish I had this information a day or two sooner. I could have really put this kid on some experimental drugs or extended the life, if not saved the life. So that kind of triggered my IT head a little bit, and I said, you know, in this day and age, information should not be traveling the way it should be. And I started really looking into the whole area of DICOM images in radiology, HL7 data, and all that sort of good stuff. Enlisted a small team of people who started designing something which we call My Personal Health Record Express, saving lives through technology. I really was moved by that idea of really saving a life, and I said, hey, no matter what, I've started so many businesses, but the greatest incentive that one can really get, I mean, of course, you know, the Lord saves lives, but at least I can help in this entire area. That was my personal incentive to really be into this business. So we put together a very good team, and all of a sudden I realized, like my previous companies, that developing anything in the United States, in the Western world, was a very, very difficult and an expensive process. So we put a team together, and I had offices in Bombay, thank God, and put together a nice team there in actually New Delhi, where we have our development offices now. And I started hunting for a Vishnu. So we went, and it was basically, my idea was on a piece of paper, and at this time, we had not invested too much money into this concept as yet as to how to move images from point A to point B, okay, without actually putting them on CDs, without putting them on any sort of images and sending them right across electronically. And these mammograms and these CT scans are huge files, very, very big. And anything could get corrupted, the data could get lost, whatever have you. So I befriended a gentleman by name Dr. Ahmed, who was the CEO of Max Hospital. It's a chain of hospitals, one of the finest hospitals in North India. And I went and presented my idea to him in April of 2008. And I said, Dr. Ahmed, if I could really put this technology together, would you be my buyer, my Vishnu? And so he said, absolutely, this is a great idea, and I'll really back you up all the way. So the point I was trying to make here is that you really need somebody to back your idea up before you even start investing any time or money into the business or anything that you're really doing, because that's the most important thing right from the top down here. So we developed the technology. We started looking into what exactly does really prevent an image to be transferred. So we looked into something called a PACS system, Picture Archiving and Communication System, that most imaging centers have today. And this actually, if you look at it, is nothing but a piece of iron. It's a server, and it's got some software in it, and it just stores your images, and that's all it really does. And I started looking around for some of these prices in the United States, and they were anywhere from $500,000 to $1 million, and something called a Super PACS was sold for $3.2 million. And I said, oops, that's where the healthcare costs are really going up. I mean, we talk about costs all day long, about this and that, but we never really look into even calling up a General Electric or a Fuji or a Toshiba and say, hey, listen, I'm not going to be paying you $3.2 million for a super PACS. When was the last time our hospital administrators ever did that? Then I realized that the same GE machine or whatever, the Fuji PACS machine, was sold at 1/10 the price in India. There's a huge price differential between what you have to pay in the United States and Canada versus in India. So I went and got a CT scan done by myself at a hospital called Artemis, 64 slice, and guess how much I paid? $100. Just $100 for a full report with images and the whole 9 yards. And the price for something comparable over here was about $3,000 to $4,000 at that time. So I suddenly thought that this is a huge opportunity here. Why not get rid of this PACS machine altogether? And we started investigating further and found out actually that the NIH in the United States has developed a PACS, is it open source already. So we picked up this open source PACS and we put together in what we call today as a cloud service, okay, right in our server in the cloud. So now we have a PACS free of charge, okay. We put in mammograms in it, we put any size images, whatever have you, right in there into our cloud. And we can store it, we can archive it, whatever have you. Then we said, okay, fine, what about a viewer now? That exists as well. We really did not have to make a viewer. It was in open source. So then people heard about our project, Microsoft and some of the other companies. They said, hey, we want to really give you all the software for free. Why don't you use our platform? So I got very excited, actually, and talked to my team about using Microsoft technologies to develop the product. And they came back and said, no, don't really do this, because once you start developing it on a platform, then later on, they're going to charge you a lot of money. That's where your costs are going to really drive up very high. So we stuck to open source, which is free. So now I've got my PACS free, I've got my viewers free, we've got the software free, everything. The database is free. There's no charge whatsoever. And now I've got this customer, Max, which is willing to really spend all their time and money with us to develop the product with us. So we were successful in essentially sending images from any PACS machine at any hospital or any modality. Need not be PACS, but if they had a PACS, we connect to the PACS, straight to the cloud, where we store these images in the cloud, and they can really be viewed anywhere in the world on a mobile device like an iPhone, iPad, cell phones, or PC, laptop, whatever have you, instantaneously. So you could technically today use our technology, and a physician can send you to a care delivery organization like a imaging center or hospital. You get an image done, and now within seconds, the physician gets the images as well as the reports right onto their cell phones and iPhones, okay, wherever they are. They could be a physician right here, and using our technology, you could really access the images of the patient. So what happened was, about in April of this year, a patient went into Max, and they had a problem of the abdomen, and the surgeon in the middle of the night refused to operate because he says, you know, I really don't know exactly where to perform the surgery. And I'm not really a doctor, so pardon if I do not use the right terms here. So the radiologist was about 4 hours away, and he said, why don't you come here? And the radiologist said, you know, by the time I come there, you know, the patient may just die. But he had a BlackBerry torch in his hand, and so he was able to see the images right then and there and tell the doctor exactly what to do. And the surgery was successful. We were covered with the CTO Forum magazine cover story about how MphRx saving lives through technology. And just like day before yesterday, RIM gave us the most useful application on their BlackBerry award our country manager of India is going to be receiving that on December 7th. So to going back, the reason why we were successful was because there was just one believer in our innovation, and that was the CEO of the hospital. We got a lot of flack, trust me on that. A lot of people said, no, this is no good, including the chief of radiology. He actually did not know how to really operate an iPhone. Trust me. So we had to go and teach him how to do that. So then we came back and said, all right, going back, I've always been a firm believer that if I could sell a product, an idea in India, I can sell it anywhere in the world. India is the toughest country to sell anything. Okay, very, very difficult. Okay, price-wise, negotiation, bargaining, they'll just hunt you down, crazy. So the idea here is essentially reverse innovation, in the sense that this is a term that was coined by Jeff Immelt, which says basically that you can really learn something from the developing world and apply it in the industrialized world. This is what exactly we did. We learned the art of making an inexpensive product in India, and now we're selling it in the United States and Canada, okay? Because cost is a huge element. It helps you essentially lower the cost of healthcare, plus also selling becomes a lot easier when you know that your base cost is very, very low. So we came back to the United States, and we got hold of our second Vishnu, which is the largest privately held imaging center in the United States, DIG Group. And they've got about 50 imaging centers that are using our technology today to essentially send these images right from the modality to the cloud, from the cloud to the physician. So now, here we go. We've cut the cost of CDs. There's no more CD making over there. There's no more people who are really following up with these physicians to see if they've got the reports or not, okay, or the images or not, the CDs. And third, there's a study which says that 64% times these CDs do not really work when they're sent back, when they're sent to the physicians. So we've solved a major number of problems in one shot right there for these. Secondly, we also, now that we have all these images in the cloud, we give them what is called as disaster recovery and business continuity. So in case of floods, and there was Hurricane Irene that literally happened, and where the entire services were shut down, they were able to use our cloud to be able to access them. We have our service data center in Miami and the backup in Atlanta to be able to, offer them this kind of a service. Then we started looking further into what else could we really do with this technology? How, now that we have really perfected the art of sending images from point A to point B and putting them on iPhones and iPads, whatever have you, what else can we really do with this? We started looking into the whole idea of in the diabetes market. There's an element of a vision loss to about 3 or 4%. I don't know exactly the percentage, but somewhere around there, of people who get retinopathy who are diabetics. We did a little bit of research, found out that most of these patients, they actually are lazy or they procrastinate going to an ophthalmologist to get their annual eye exams done. We partnered with this company which makes fundus cameras called Nidec. And when a patient visits a primary healthcare professional, these cameras are right there, very simple to operate, and you just put your chin up there and the images of the eyes are taken and they go straight to the cloud, from there to a network of ophthalmologists who are doing these reads, and basically they say, hey, listen, this patient really needs to come and see me, or he's fine. And now the benefit is that the patient really does not have to make 2 trips, does not really have to visit another ophthalmologist. Now he's already gone to his primary care physician. And secondly, if there is a need for retinopathy, the test is being done, or the surgery or whatever has to be performed, and this ophthalmologist gets a referral from this process. So this has become a very, very popular program in Atlanta. We've just launched it in May. And there is another state that we want to cover very soon, which is in Florida. So because these two apparently have the highest percentage of diabetics in the United States. So some of these innovative ideas, once again, we approach from a cost-cutting model where we are really, and also to give efficiencies at the same time. We really want to make sure that it makes sense. A lot of these ideas when we come up with, if they do not really make sense, they really go out of the door very soon. So we went to a major hospital in New York and said, listen, what do you do with your lab reports? So they say, well, we email these reports to the physicians, or and plus we put them in the first-class mail. And there's a law in the state of New York which basically says that every time you send a report, you've got to get a feedback from the doctor saying that he or she has indeed received those reports. So since our technology gives you an audit trail saying that who got it at what time with a complete idea of each and every physical movement of that data or the image, it is very easy. That was done for us. So I was actually in this negotiation table with this group of doctors as well as administrators, and they said, you know, your price is too high, et cetera, et cetera. So I asked them, I said, what is the bulk postage rate that you all spend on these lab reports that you send out? So they actually did not know what the exact amount was, but it was somewhere around 39 or 40 cents, somebody said from the hall in the conference room. So I said, how many do you really do? So they said, we send out 12 million a year, 12 million lab reports. So I said, okay, just give me that money, and I'll do this for you electronically. I did a quick math there. And so just a point here is that none of these chief administrators or whoever was in this room even realized that there was something called a postage cost. I don't know where it was really going, okay, on what budget or who was really paying for postage in this hospital, but the fact of the matter is that these are some of the things that, you know, hospitals, healthcare really has to really look into. This is very, very important because we keep talking about healthcare costs rising on a daily basis, but we don't really figure out, you know, ways of really cutting these costs down. And, you know, if you really look at it, 12 million times 0.4, that's a lot of money for a major hospital, okay? So these are some of these basic fundamentals on which we have really had our initial success, if you may, because we just started marketing our product this year, January of this year, and have been really, grace of God, got into some very major hospitals and care delivery organizations, both in the United States and in India, and doing quite well. So I was then invited to the telemedicine conference in India last week, or was it week before? And I was quite surprised to see Anish Chopra, the Chief Technology Officer for Barack Obama there, Lord Nigel Crisp, the ex-British National Health Service CEO, he was there as well. And I started to wonder what exactly, you know, they were doing. I mean, these very high-profile CEOs and CTOs right in a place like Mumbai. And I had the opportunity of speaking with them. And they both mentioned to me that they really learn a lot from this so-called reverse innovation that we were talking about earlier. And that's why they were really present. And as a matter of fact, he said, Lord Nigel said that we can really learn from some of the things that are happening in the developing world. And so let me just share with you some of the things that are happening in India. There is a very good group called the Arvind Eye Care Clinic. I think most of you may have heard about some of the wonderful work across the world that they're doing. And they have really put together a model of doing cataract surgeries, okay? And it's almost funny to say, but they've used the model from, like an assembly line or a food processing or a fast food chains. That's how they've really put together and trained their staff of doing cataracts. So now, let's say that you have to do a cataract today in the United States or Canada. Okay, it's one patient, a surgeon comes in, and there's all the overhead is all assigned to just one patient alone. Whereas now, here, they're doing what is called as volume cataracts, okay? It's almost like an assembly line. So one patient comes in, the other one leaves, the other one comes in, it just goes on and on all day long. And guess what? We all thought in the very beginning when they started this that the quality would be very poor, okay? And because, the charges were absolutely very, very low. But let me just tell you that the percentage of complications were 50% of those that were in comparable circumstances in the United Kingdom at 1% of the cost. At 1% of the cost. So now, the healthcare innovation really plays in terms of really bringing about efficiencies and cost savings in anywhere. You can really put this model together in Canada, I'm sure. You can put this in United States. There's no question about that. United States is really, and I don't know much about the Canadian market as much as I do about the United States. They're all really honing in on technology, on EHRs, EMR implementations. We have, with this DIG client, they've got 30,000 physicians that we are servicing, or that's how much we will end up servicing. We've got to about 3,000 people who are using it. We found out that 80% of them do not have an EMR or EHR system. So I visited a few of them at their offices. They didn't even have computers. But they did have smartphones, all of them, each and every one of them. And so when we gave them our application, they loved this, okay, because now they say, hey, I really don't need a PC anymore. So the idea is that we are implementing EHRs and EMRs, and our 80% in the area, New York area, I still don't have PCs in their offices. And so where are these EHRs and EMRs going? I mean, they're basically saying, hey, listen, this is the meaningful use. By 2015, you've got to have this, otherwise there's a penalty. There is this, there is, and you talk to these doctors, they say, you know what, I'd rather be out of business than use a complicated EHR or EMR system. This is their response to us. So when you make things simple for them, when we made this application, we made it a zero app install, in the sense that the doctors didn't have to do a thing. All they had to do is just put in their password and name, and that's it. They got all their patient records right there. Make it simple and keep the costs low, and I guess you can really go about innovating anything that there is. One other subject that I do want to cover before I end here is the whole area of telemedicine. That is going to be the wave of the future. Today we saw Dr. Snowden talk about different countries, comparing, several countries in Europe to Canada to United States. However, all these walls are thinning on a daily basis. There are a number of patients who fly today from Europe to India, okay, as part of the medical tourism to get their surgeries done, okay, because the waiting times are so long in some of these developed countries that they come to India and get their surgeries done at much lower costs today, okay? So the whole world is so global right now that, we cannot really start comparing each and every statistic from one place to the other. What I mean by that is that when you're looking at a country like India, and you see some of these cities and you see the rural areas, there's a night and day difference. In the cities, you have people coming in from overseas paying market rates from some of these surgeries, whereas in the rural areas, the amount that is being charged to the villagers or to the poor is actually very, very low. However, both those models which we have in India going today, both of them are indeed making money. Okay, they are indeed making money because of the fact that there are volumes, okay, in the rural areas, whereas in the cities they are really being served at a very high price. In Canada, we have 70%, I was reading today in today's newspaper, 70% of people actually die in hospitals. Okay, and can you imagine the cost over there? Why? We can definitely look into another area of innovation where we can bring some of these citizens right to their homes and use technologies such as telemedicine to be able to communicate. All that people really want is communication with their physicians, with their surgeons, or with the doctors, whether they are at the hospital or at home, and to be able to get the necessary guidance. And I think the technology exists. It's just that we need someone to really be able to going after them and implementing those. With that, thank you very much.